neuropathy with Pregabalin controlled release. So the next 25 minutes or so that I have, we'll try and focus not only about Pregabalin controlled release, but also about diabetes, the peripheral neuropathy, the painful neuropathy, and the impact that it causes in the lives of a diabetic patient. So what are the goals of diabetes management? Can anybody tell me the goals of diabetes management? Yes. To prevent complications, fantastic. What is the other goal of diabetes management? Fantastic, quality of life. So it's not only about just controlling A1C, preventing complications, but it's about the quality of life. The patient should be living with a good quality of life rather than a poor quality of life. So when we talk about complications, it's preventing complications and optimizing quality of life in goals of diabetes care. So many a times in clinical practice, we focus on preventing complications, but we tend to forget to improve the quality of life of a diabetes patient. And by managing diabetic neuropathy or painful neuropathy, we are actually addressing both these things. We are preventing or trying to prevent the complications of diabetes as well, and trying to improve the quality of life as well. Now I am giving a talk here today. अगर मुझे इस वक्त सर में दर्द हो रहा होता और अच्छी बात है कि नहीं हो रहा है, तो मैं कैसे talk देता या किस दिल से talk देता? It would have been extremely difficult to go on and give a talk. Realize somebody who has burning soles, pain in the feet, he has to go on and live his life every day. I mean, what a misery it is, and what quality of life that person will be having who has painful diabetic neuropathy. So again, diabetic painful neuropathy, the prevalence is around 50 to 90%. Out of these, 40% will be having symptoms that will bring them to you: burning soles or painful feet, tingling sensation, electric shock-like symptoms. Around 10% may go on to develop an ulcer, and then the feet or the leg gets chopped off in circumstances which should never happen in view of diabetes management. So again, if you see the microvascular complications, the retinopathy, the nephropathy, and the neuropathy, we have everything to measure the complications like retinopathy and nephropathy. So we have a fundoscopy, or you can have a retinal photograph to look at the eyes. We have creatinine levels and the urine albumin and protein measurements to look at the kidney damage, the nephropathy. But what about neuropathy? Do we have a test, or it's mostly doctor dependent? The doctor is going to get up from his seat and go and check whether there is neuropathy or not. What do we have? Clinical examination, good. History taking, clinical examination. So mostly we are relying on history, and we are examining patients in our clinic to get to the bottom of diabetic neuropathy. And this is what happens around the globe mostly. So that's why the diagnosis gets delayed. So now look at what happens in general practice in the world. How much percentage of diabetic peripheral neuropathy remains undiagnosed? Look at the 90, 80%, and these countries are none other than Malaysia, Saudi Arabia, Germany, Taiwan, Hong Kong. More than 80-90% of the diabetic peripheral neuropathy remains undiagnosed in primary care. And this is a call to action. So we need to pick up diabetic neuropathy earlier in the primary care and secondary care, not at the level of the tertiary care at the most. I'm sorry, every time I click one, it moves to ahead, right? So what is the problem? Where is the problem? So in diabetes, we know it's a peripheral neuropathy, right? Mostly that comes in. The small fibers, they get affected first, and then the large fibers. And what are the examination that we do to pick up diabetic neuropathy? What do we do in the clinics? Chale khul ke batana hai. Yes. Monofilament and vibration. Now look at monofilament is here, touch, vibration and position. All these measure the large fiber neuropathy. The large fiber damage will come at a later stage. Not later stage, I must say a much later stage, after the small fiber damage has come in. So what we are doing by doing a monofilament and a vibration is by checking which feet are at risk of ulcer, because these feet who have a monofilament which is not coming out positive, it's damaged, or a vibration sense that is not there, it's a foot that has already advanced diabetic peripheral neuropathy. We are not checking the small fibers. For small fibers, the best is a cold or warm sensation or pain, pinprick pain sensations. And then the autonomic neuropathies. This is where the problem lies, right? So again, this is the corneal confocal microscopy, and you listen to Professor Rayaz Malik, who is always advocating the corneal confocal microscopy. And does anybody in any center of Pakistan, do we do this microscopy to look at the nerves? Yes or no? Anybody knows about the corneal? We don't do. I tried and contacted institutions. Do you do corneal confocal microscopy? He said, we look at the retina through it, but not the cornea. But not the cornea nerve fibers. But in some centers, they have the microscopy there, and it can be done. But only it's that we need to propagate and advocate this message that this is the earliest complication of diabetes that we can actually pick up. At the moment, neuropathy is the worst, in a miserable situation, not being picked up. And usually it's picked up automatically when the patient has significant symptoms, it just comes to light. But by doing corneal confocal microscopy, it can come up early. So again, diabetic peripheral neuropathy should be suspected in type 1 diabetes of 5 years or more duration, and all patients of type 2 diabetes and patients with idiopathic painful neuropathy always screen for pre-diabetes, because 50% of such patients, they have pre-diabetes compared with 14% of the general population. And you all must have seen that even a pre-diabetic comes in with burning feet and tingling sensation, and you go on and check and it's a pre-diabetes. So neuropathy is even coming up before diabetes is actually diagnosed in the pre-diagnosis, in the pre-diabetes stage. So the problem is the quality of life. Once you have this pain, when you have these burning feet going on, you are unable to concentrate and focus on your work. You are unable to do your daily routine jobs. And this is where depression and anxiety comes in. This is where sleep disturbances comes in. And the whole quality of life starts to go down. And the quality of life is both inside the house and outside the house. Outside the house, somehow these patients will manage. But inside the house, there will be disaster and problems, right? Because आदमी फिर घर में ही गुस्सा निकालने लग जाता है ना, बाहर तो लोगों को आप नहीं कुछ कह पाते हैं. This makes a huge problem with households. मैं इसकी डिटेल में भी नहीं जाना चाहता क्योंकि टाइम नहीं है. Look at the countries in the MENA region, the diabetic painful neuropathy prevalence, around 40-50% prevalence in countries like Saudi Arabia, Syria, Iran, Yemen, Turkey. And if you see Pakistan, this was a study done, the incidence, the prevalence of diabetic peripheral neuropathy is 43%. And newly diagnosed diabetes, the prevalence of peripheral neuropathy is 26%. Now, this is a complication you start facing right at the start of diabetes. Now, this is the mechanism of diabetic peripheral neuropathy. It's hyperglycemia, insulin resistance. You have multiple pathways, and then you move on. You have oxidative stress, mitochondrial dysfunction, ultimately leading to inflammation, damage of the blood vessels that supply to the nerve fibers, and the damage is consistent throughout the body, more so in the distal parts than in the earlier parts. So again, types of diabetic neuropathy, the most common glove and stocking variety, you see the small fiber neuropathy coming up early, and then the large fiber neuropathy. You also see the entrapment neuropathy, the diabetic autonomic neuropathy, radiculopathies, and focal or multifocal neuropathy. By and large, the peripheral neuropathy, the small fiber peripheral neuropathy is the most, and this is what we tend to miss. So again, the sensory symptoms can be positive symptoms and negative symptoms. The positive symptoms is when patient feels more, so he has spontaneous pain, or allodynia or hyperalgesia, dysesthesia, paresthesia, very similar terminologies. Negative symptoms like hypoesthesia, anesthesia, hypoalgesia, and analgesia. The negative symptoms might not be too troublesome, but the positive symptoms are. And in most patients, both negative and positive symptoms, they coexist in at least half of these patients. Now, mostly the patient complains of burning sensation, tingling, electric shock, stabbing, uncomfortable numbness. What is it that worries you when the patient starts telling you that he has all these symptoms? If a patient diabetic, A1C is 8.2, comes to you with all these symptoms, क्या चीज़ आपको परेशान करेगी उस वक्त? Complications have set in. Neuropathy coming in means, and the symptoms coming in means the complications have started to come in. What else worries you with this? और क्या परेशान करेगा आपको? One of the first microvascular complications to come in, one of the last to get picked up, right? So again, moving forward, how to know that this is diabetic neuropathy? So again, it will be symmetrical, usually insidious, slow in onset. Sensory symptoms are more than the motor symptoms. Lower limbs affected more than the upper limbs. Ankle reflexes, they are lost first. Small fiber damage comes in first, which is intense pain measured through pinprick and temperature sense, and then the larger fibers that get affected, the vibration and position sense, which we check in our clinics, right? So again, diabetic peripheral neuropathy, diagnosis and screening. So moving forward, you have somebody who is a diabetic, or if it's an idiopathic neuropathy. In an idiopathic neuropathy, you know, you always need to screen for diabetes, right? Now, so in diabetic neuropathy, if you suspect this is diabetic neuropathy, you have a patient, you can take history. You need to exclude the non-diabetic causes. Is the patient taking alcohol? Is there any B12 deficiency that is there? Is there any other reason for neuropathy in this patient? So is it diabetic neuropathy or is it neuropathy in a diabetic patient? So again, neuropathic pain is prevalent across a range of different clinical conditions, right? So you have got a lot of peripheral neuropathic pain and lot of central neuropathic pain. Now, if you see peripheral neuropathic pain, diabetes, of course, holds the bulk of these neuropathic pains, but it can be cancer, it can be HIV. Studies have shown even HCV can cause neuropathic pains, post-surgical, chronic low back pain, or post-herpetic neuralgia. Again, in central neuropathic pains, stroke, spinal cord injury, multiple sclerosis. So in diabetes, if there is neuropathy, keep your mind open. This can be other neuropathic pains as well, apart from diabetes as well, right? So think if clues. So just think about this. If it's a rapidly progressive or abrupt onset neuropathy, this can be other reason other than diabetes as well, right? Then if it's a prominent motor abnormality or cranial nerve involvement, again start thinking this may be other than diabetic neuropathy. Large fibers affected more than small fiber, not typical of diabetic neuropathy. Involvement of the entire lower limbs without any involvement of the distal upper limb, again this can be other than diabetes as well. And prominent hands and upper limb sensory symptoms rather than the lower limb symptoms, again think this may be other thing. If you are not sure, you can always go on and do a nerve conduction study. You can always go on, take help of a specialist or even a neurologist if you're not sure, right? But more often than not, these patients would be having diabetic neuropathy. So the diagnostic challenges, diverse symptoms, multiple complex mechanisms, difficulties in communication and understanding the patient's symptoms, and the comorbidities that are together also cause the problems. So again, how to diagnose diabetic neuropathy, how to screen the diabetic neuropathy. So there are a lot of interview-based and interview for a plus physical test setups, questionnaires, and guidelines. The most commonly that is used is the DN4, which has 7 symptoms and 3 clinical exam items. So again, the sensitivity here is 83% and the specificity is 90%. So there are 7 questions. Does the patient have one of the following characteristics? Does the pain have any one of the following characteristics? Burning, painful cold, electric shocks. ये 3 सवाल हो गए. फिर is the pain associated with one or more of the following symptoms in the same area? Tingling, pins and needles, numbness, itching. Itching कितनी बार पेशेंट डायबिटिक बताता है और हम क्या कहते हैं उसको? एलर्जी हो गई है. This might be allergy. Itching is a symptom of diabetic neuropathy. Patients always, many times complain about itching, and many a times it is considered as some allergy rather than neuropathy. And then the third and fourth question, which is physical exam. So is the pain located in an area where the physical examination may reveal one or more of the following characteristics? Hypoesthesia to touch and hypoesthesia to pinprick. And in the painful area, can the pain be caused or increased by simple brushing? So 3 चीजें physical examination की हैं, 7 चीजें, the questions, and you can get, and if the score is 4 or more, you say this might be diabetic peripheral neuropathy, right? So these are simple things that you can do in clinic to get a certain idea whether this is painful diabetic neuropathy or not. Again, the tests that we do, monofilament. Monofilament कौन से fibers को test करता है? Yes, monofilament कौन से? Small fiber, large fiber को test करता है. अस्सलाम वालेकुम सर. Monofilament tests the large fibers. तो ये तो late diabetic neuropathy बताएगा. Vibration test, large fibers. Again, late diabetic neuropathy को बताएगा. Pinprick tests the small fibers. This will pick up things earlier than vibration and monofilament. And hot and cold, the thermal allodynia, this will again pick up the small fiber damage earlier. So again, management of diabetic neuropathy. So diabetic neuropathy is something that we always need to ask patients. Patients will only tell us when there are serious symptoms, right? But we need to examine, we need to ask patients. History and examination remains to be the key yet today in diabetic peripheral neuropathy. The management guidelines. What should be the first management of treating diabetic neuropathy? Foot care, treat the complications. पहला काम क्या करना है? Patient with an A1C of 9 has diabetic painful neuropathy. पहली चीज क्या करेंगे? Control diabetes. Young people, intelligent people sitting right behind. Great, fantastic future. So again, control diabetes is the number one thing that you need to do. And I'll tell you why that is important, right? So again, whether it was 2015 or 2025, the guidelines for management of diabetic painful neuropathy remains the same. So you start with, you have medications like anticonvulsants, the SNRIs, the tricyclic antidepressants. If there is no effect, you switch to the other group. If there is partial effect, you can go with a combination therapy, right? Avoid opioid analgesics, but some guidelines would still suggest to go with it. Now, if we look at the management of diabetic painful peripheral neuropathy, exclude non-diabetic etiologies. If the patient is taking alcohol, is it B12? Is it motor more than sensory? Is it upper limbs more than the lower limbs? Try and think, is there other than diabetic neuropathy, right? Stabilize diabetes and metabolic control. Not only diabetes, cholesterol control, blood pressure control. Quit smoking because that can cause peripheral neuropathy as well. Pain management like pregabalin, TCAs, duloxetine, tramadol, topical capsaicin, and combination therapy. And then you can always refer to specialist, neurologist, or pain clinic to the patient. Now, intensive glycemic control was associated with the reduction of 40 to 60% in the development or progression of neuropathy. Sometimes we are too quick to go to the medication part, but we tend to forget that half of the neuropathy or the painful neuropathy can go away just by managing diabetes well, right? So this is very important that diabetes should be managed. Many a times we see patients on medications for peripheral painful neuropathy and the diabetes is absolutely uncontrolled. So the diabetes control has to be there before we actually go on and give any medications in these patients. The incidence of neuropathy, this is very important, the Eurodipe trial, the incidence of neuropathy is also associated with modifiable CV risk factors like increased triglycerides, increased body mass index, smoking, and hypertension. So it's a whole metabolic management that will bring the neuropathic symptoms down and not only medications. And this is where I want to put your attention to. So again, this is the mechanism-based pharmacological treatment of neuropathic pain. So this is the whole system. We see the alpha-2 delta ligands, the pregabalin acting at this stage, medication affecting the central sensitization. We see SNRIs affecting the descending modulation, TCAs acting on both of these mechanisms. So again, if you see the role of alpha-2 delta linked calcium channels in neuropathic pain. So what happens is in nerve injury, the injury stimulates production of the calcium channels. The calcium channels are transported to the nerve terminals in dorsal horn. This increases the number of calcium channels, more calcium influx, more neuronal excitability, more pain. And the alpha-2 delta ligand, the pregabalin, actually goes on and blocks this whole system. And that is exactly how it controls the neuropathic pain in diabetes. Let's go on and look at the guidelines. The American Diabetes Association would say the gabapentinoids, the gabapentin and the pregabalin, the serotonin norepinephrine reuptake inhibitors, SNRIs like duloxetine, tricyclic antidepressants, and sodium channel blockers are recommended as initial pharmacological treatment for neuropathic pain in diabetes. This is American Diabetes Association. Look at And look at this, the optimized glucose management to prevent or delay the development of neuropathy. कोई भी guideline आपको treatment बताएगी peripheral painful neuropathy की, glucose control is the first part that is there, right? So Canadian Diabetes Association would say diabetes should be treated with intensified glycemic control to prevent the onset and progression of neuropathy. Again, when they tell about medications, the first line is anticonvulsants or antidepressants. The second line is opioids. Now look at the anticonvulsants for neuropathic pain, more commonly given, so gabapentin, pregabalin and valproate. Pregabalin, plain, not the CR formulation, is given with a dose starting with 75 milligrams BID to up to 600 milligrams per day. The FDA recommendation says 300 milligrams for diabetic painful neuropathy should be enough. And these are the antidepressants for neuropathic pain: amitriptyline, duloxetine and venlafaxine. Antidepressants का फायदा ये है कि patients are depressed also. So if patients have depression and diabetic painful neuropathy, probably you can give the SNRIs or amitriptyline. Pakistan Endocrine Society's third diabetes guidelines, which were released in 2023 May, pregabalin, duloxetine or gabapentin are recommended first-line treatment for neuropathic pain in diabetes. Now pregabalin CR, now if you see, you give patients a lot of medications. आप diabetes की दवा देते हैं, आप 2 दवा, 3 दवाइयाँ, 4 दवाइयाँ, then hypertension, then dyslipidemia, then you have, in some patients you might give aspirin in high risk of cardiovascular disease patients. And then you say, okay, it's diabetic peripheral painful neuropathy also, तो हम आपको pregabalin भी देंगे. And pregabalin plain is given, usually given twice a day, right? So again, the big problem with diabetes is not that you and me are not giving medications. The big problem comes to adherence, and that's why combination therapies in diabetes are gaining popularity. In hypertension, you have combination therapy. In diabetes, you have combination therapy. Again, when we give pregabalin, it's twice or thrice. The dose is 2 or 3 times daily, ideally. But with pregabalin CR, the advantages are that meta-analysis demonstrated significantly better adherence rates for once daily dosing regimens compared with twice, 3 times or 4 times daily regimens. Can anybody tell me, studies क्या बताती हैं, how much is the non-adherence in diabetic patients? कौन बताएगा? Non-adherence कितनी है? आपने बेहतरीन दवाइयाँ लिख कर दे दी. What is the non-adherence in diabetes management? कितनी % में? 100 में से? Yes. Guess करना है, मैं कौन सा कोई marks देने लगाऊं? 40%? More than 50 studies have shown up to 70% non-adherence in diabetic patients. आपने बेहतरीन नुस्खा लिख दिया, मरीज ले ही नहीं रहा आगे से, ठीक है? So steady drug levels with the CR, pregabalin CR, you need to give it once daily. Control release allows for more consistent blood levels of the medication, reducing fluctuations and improving symptom control. Reduce side effects because it works in a slow release format. The side effects like dizziness, somnolence and peripheral edema gets blunted. By maintaining more stable levels, it has fewer side effects compared to the immediate release versions. Improved dosing convenience, I already told you the pregabalin CR has to be given once daily. You can conveniently give it at night time. Better symptom management, studies have shown that it has slight edge over symptom control. कैसे हैं सर आप? So it has slight edge over symptom control compared to the immediate release pregabalin. So again, we always think about reducing the medications rather than giving pregabalin 2 or 3 times a day. It's very important to give CR once daily to improve beneficial impacts as well and to reduce the negative impacts as well, right? So again, but you in pregabalin, whether it's plain or whether it's CR formulation, it's excreted through the kidneys. So creatinine clearance has to be taken in consideration. So if it's a normal renal function, creatinine clearance is more than 60. You start with 165 milligram once daily, and the maximum dose is 660 milligram per daily. But for diabetic painful neuropathy, you go up to 330 milligrams per day in most cases. For fibromyalgia, you can go even to 660 milligram per day. For mild renal impairment, creatinine clearance between 30 and 60, start with the lower dose, 82.5. And even with normal kidney function, I have a practice to start with lower dose, 82.5. And we can always go up to 165 and 330 if needed. Zyadatar patients go in my practice, and we'll hear from the chairs, I start with 82.5 and go up to 165 and get a very good response in 165. And in many few patients, I need to go up to 330 milligrams. So again, in mild renal impairment, you again start with the low dose, 82.5. In moderate renal impairment with creatinine clearance between 15 and 30, remember not to exceed 165 milligrams. And in severe renal impairment, creatinine clearance less than 15, you keep going to 82.5 milligram once daily. And if the patient is on dialysis, because it washes out in dialysis, pregabalin. So after the dialysis session, you give the dose. You keep it 82.5 milligram once daily, but on the day of dialysis, you give it after dialysis, right? So again, pregabalin CR versus immediate release and peripheral neuropathic pain. The efficacy and safety of the CR pregabalin and the immediate release pregabalin capsule for peripheral neuropathic pain. And I'll just read out the conclusion. The pregabalin once daily tablets, and this comes in tablet, the CR. The pregabalin is in capsule. So pregabalin once daily tablets can be effectively and safely administered to patients with peripheral neuropathic pain. Furthermore, we found that sleep, anxiety, and depression were improved with pain control, and I'll come back on this. Owing to the once daily administration, treatment effects can be maximized by improved treatment compliance. In diabetes, how many times do we check whether our patient is depressed or not? कितने लोग check करते हैं? हाथ उठाएंगे? आगे से हाथ उठ रहे हैं जो हम expect करते हैं. Quality of life. क्वालिटी ऑफ लाइफ के क्वेश्चनर्स देखेंगे, 100 क्वेश्चंस का भी है, 23 का भी है, 15 सवाल का भी है. कल सुबह जो हम बात करेंगे तो वो और छोटा 13 क्वेश्चंस का है. दीज आर थिंग्स. कराची में तुम क्वालिटी ऑफ लाइफ को अहमियत देते ही नहीं है. कराची वाले खास तौर पे सर आप लोगों के लिए बता रहा हूँ जो. So in Karachi, even this is a huge problem. So moving forward, just last couple of slides, I have 3 minutes. More efficacy and safety of a new sustained release pregabalin formulation compared with immediate release pregabalin in patients with peripheral neuropathic pain. And you see the black bars, the response with SCR or SR pregabalin is better in terms of response for neuropathic pain compared to the immediate release pregabalin. And remember, the goal of treatment in peripheral neuropathy is not to get it 100% down to normal. Remember the ABCs, it's always diabetes control coming up right at the top. Diabetes ka A1C 8, 9, 10 hai aur aap pregabalin CR bhi de rahe hain, it will do nothing. So diabetes control has to be there and patient needs to be understanding this. ये ना हो कि आपने pregabalin CR दे दिया, वो समझो ठीक है अब तो बस खाते रहो, pregabalin CR ले लूंगा तो burning sensation will go away. That will not be the case. And the goal, more than 50%, if you have reduced the painful neuropathy, this should be your first goal. But the secondary goals, which are more and more importantly coming up to the primary goal, is the improvement in mood, quality of life, function and sleep. मैं हमेशा कहता हूँ कि बहुत ज़रूरी है कि डायबिटीज़ के मरीज़ का HbA1c 6.5 हो, लेकिन ये भी ज़रूरी है कि उसका घर चलता रहे, उसका अपने स्पाउस से रिलेशनशिप अच्छा रहे, बच्चों को भी इखलाक से बात करे और टाइम दे. ये ना हो कि वो डायबिटीज़ के सिम्टम्स उसको उस हाल पे पहुंचा दें जहाँ उसके घरेलू रिलेशंस. और हम कितनी बार मरीज से पूछते हैं कि कितने लोग घर में रहते हैं, कैसा रिलेशनशिप है, बच्चों को कितना टाइम देते हैं. ये वो चीज़ें जो हम बात ही नहीं कर पाते हैं क्योंकि हम कॉम्प्लिकेशंस पे ही बात करते चले जाते हैं और ट्रीटमेंट पे ही बात करते चले जाते हैं और ये चीज़ें रह जाती हैं. So coming up to the key messages, neuropathic pain in diabetes is highly prevalent and must be diagnosed and treated to improve quality of life. Most treatment guidelines consider alpha to delta ligands and antidepressants as first-line therapy for most types of neuropathic pain. Pregabalin, of course, has proven efficacy and safety and is there as a first-line treatment in all guidelines. Consider pregabalin CR to increase adherence and convenience. With this, thank you very much, and thank you very much PSIM for once again inviting me here. Thank you very much.
Thank you, sir. It was an excellent presentation. Now there is time for only one question from the audience. And please identify yourself and ask your question.
I'm extremely happy to see a full house, and even you guys need to be congratulated for this win. Fantastic
This
audience.
is a sponsored session and being sponsored by Nabi Qasim.
Nabi Qasim,
hats off to them.
Full session. Huh? मैं जब आया था सुबह 8 बजे तो मैंने कहा शायद थोड़े से लोग होंगे.
I'll welcome the co-chair, Professor Tariq Wasim, and I'll ask him to